Good evening. Welcome to Best of the Day from the 55th annual meeting of the American Society of Hematology. This evening, I'm meeting with Dr. David Steensma from the Dana-Farber Cancer Institute. We're going to talk about some of the data that was discussed at this year's meeting regarding myelodysplastic syndromes and myeloproliferative neoplasms. So David, welcome once again to Best of the Day.
Thank you, Jim, for having me. This is always great fun. Good chance to summarize the highlights of the meeting.
It is enjoyable, and I can't say there were a tremendous number of highlights in MDS this year. There's been this ongoing background rumble in the genetics of MDS, and it seems like every year there's another new genetic mutation that's discovered. A couple years ago, we talked about TET2 and IDH1 and 2 and ASXL1 and some of the other genes that are involved in the epigenome as being important. There was a presentation this year from the Japanese Genomics project in which they did a lot of deep sequencing, DNA sequencing, and gene array analysis. And there's been a number of studies looking at this, but we haven't really seen as yet anything that identifies specific oncologically driven subgroups that we can target. And I guess that's what we're really looking for.
It is, and it is discouraging that there has not yet been an obvious, kinase or something that is responsible for the pathology in a large proportion of patients with MDS. Many of the mutations that have come out thus far in myelodysplasia have been things like spliceosome or cohesins or transcription factors or things that affect epigenetic patterning that, although there are ideas about how to target those processes, it's not as straightforward as inhibiting an overactive kinase. The Japanese study looked at 944 patients, 104 genes, and they found similar results to what had been found in the big European study led by the group at the Sanger Center in Cambridge, Ellie Papa-Manuel and Peter Campbell, that was just published in Blood recently. And similar to what had been found by Rafael Behar and the group that was published in the New England Journal about a year and a half ago, before a few of these genes like DNMT3A or SETBP1 were recognized. And that is that patients with MDS have almost all have a detectable somatic mutation or 2 or 3 or 5 or 9. And some are seen together with more frequency than you would expect, and some are seen with less frequency than one might expect by chance alone, suggesting that they are overlapping, so one is sufficient, you don't need the other for the pathobiology of the disease. But there's nothing that we can say, if you have an ASXL1 mutation, you're going to respond to drug X or not respond to drug Y. We're not there yet. We do know that patients with either P53 or DNMT3A mutations do terribly regardless of the therapy, even after transplant, very high relapse rate. So those patients definitely need new approaches, immunotherapy and such, but we have a ways to go yet.
Well, in speaking of the epigenetic approaches, we've been using azacitidine, a DNA hypomethylating agent in MDS for some time, mainly in the higher risk categories, and Lou Silverman pioneered a lot of that work. And now this year he had a presentation combining azacitidine with an HDAC inhibitor, vorinostat, which has also been around and approved for cutaneous T-cell lymphoma. So is attacking the epigenome through 2 different mechanisms likely to be a more effective mechanism, or is it also a combination that's perhaps looking for the subgroup where it's going to be most effective?
Yes. That's an important but unanswered question. And in vitro, there's clearly synergy when one combines a deacetylase inhibitor like vorinostat or one of the other drugs in that class, a number of which are currently in ongoing trials in MDS and other malignancies, and a DNA methyltransferase inhibitor like azacitidine or decitabine. So Lou had 5 years ago presented data from this same combination in a phase 1, and this was the phase 2 data, so a larger group of patients. And they found a complete response rate with or without hematopoietic recovery of 42%, and so that's better than one would expect with azacitidine alone, where the complete response rate is no more than about 15%.
Right.
Whether this is true and is superior to AZA alone is currently being tested in the US and Canadian intergroup study led by Mikhail Sekharis at Cleveland Clinic, the S1117 study, SWOG-led. And this is a 240 patient study with 80 patients in one of 3 arms, azacitidine alone, azacitidine plus vorinostat, azacitidine plus lenalidomide. Accrual to that trial has been robust, and I'm hoping we'll have data within a year or 2.
Right. Well, and azacitidine's also been looked at in the lower risk patients, the low and the intermediate 1 group, where usually it's not as commonly used, but there is some activity in that group as well. But if those patients fail to respond to azacitidine, what's next for them?
For the lower risk patients, these are often patients who get put on a hypomethylating agent because they've become regularly red cell transfusion dependent or have neutropenia or thrombocytopenia to a degree that's worrisome to the clinician. So even though azacitidine survival data was in higher risk patients, azacitidine and its chemical cousin decitabine do get used frequently in the low and intermediate 1 IPSS score risk group. Now those agents don't have a higher response rate in the lower risk group than they do in the higher risk group, so there are many patients for whom those agents fail. Right. And we saw some data this year from the MDS Clinical Research Consortium that looked at the survival in those patients. What happens to them after the hypomethylating agent fails? We know if you take all comers, mostly higher risk patients with MDS, the median survival is less than 6 months after azacitidine or decitabine. They're pretty beat up and the outcomes are poor. In this group, the median survival was 15 months, so a little bit better, but still very discouraging, and we need new agents for these patients. And there are a number of agents in development, rigosertib, Array 614, and several others that are trying to look at that group of lower risk HMA failures. IPSS wasn't designed to assess patients after they'd been treated, but these are patients who have been treated but still don't have excess blasts or a complex karyotype. So they still, if you were to apply the IPSS, would fit into that lower risk group.
Yeah, so there's still a lot of work to be done. We still need to find the specific oncologic driver. We need an ibrutinib or idelalisib for MDS.
Yes, all the other diseases are outstripping us. I mean, I guess AML we still use 3 and 7, but the lymphoid malignancy, so much good things, good stuff going on. Even myelofibrosis, we're seeing active agents.
Right.
And, so MDS, we need to get our act together.
Very good. Well, one of the more provocative presentations this year at the plenary session came out of the Washington University group in St. Louis, Tim Lay's group, and they've done a tremendous amount of work doing whole genome and exome sequencing in their leukemia populations. And this year they talked about those patients who have transformed or are treatment-related AML or MDS, and what seems to be the damage that's caused by radiation or chemotherapy. It's been noted that those patients seem to have a higher percentage of P53 mutations, right. TP53 mutations or deletions. But they came up with some provocative ideas. And why don't you tell us about their presentation and what they think they found?
Yeah, one of the younger investigators in that Washington University group presented data that was testing a hypothesis. There's this idea that the TP53 mutations that we see in secondary MDS and AML are things that we do to patients by giving them cytotoxic drugs or radiation, that the P53 mutation is a result of DNA injury from the iatrogenic exposure.
Because many of the other mutations that they looked at weren't any different than in de novo AML.
Correct, and that was a little bit of a surprise. People figured that the mutations, there would be twice as many mutations or something. The mutation burden would be greater. They didn't see that. What instead that they saw was, this was based on only 6 patients, and they were only able to detect the P53 mutation earlier in 3 of them, and one of them was a little dubious. But they went back and looked before the patient had gotten, in one case, any chemotherapy at all, a patient who had had a staging marrow at the time of an initial diagnosis of mantle cell lymphoma. And they were able to find a tiny TP53 mutant clone, less than 1% of the cells, on the order of 1 in 25,000 cells. But it had the same mutation that became the dominant mutation after the patient underwent chemotherapy and other treatments. And so the hypothesis was that we all have P53 mutant clones in our bodies, that we accumulate these as we age, and that by applying selective pressure with chemotherapy, radiation, transplant, we allow a P53 clone to outgrow. There's a couple questions that are arisen from that work. One is, it's not clear that secondary MDS or AML is actually more common in older patients who are treated with...
Who would have more accumulated abnormalities.
Who should have more time to... And you also see secondary MDS with complex karyotypes, sometimes with P53 mutations in children. And so where did the P53 mutation come from then? It wouldn't seem like they would have lived long enough to evolve some of those clones. So there's some questions about that, but it is very provocative and something that will clearly stimulate further work.
They've done great work at Washington U.
It's incredible.
It's amazing, some of the stuff. Well, they've been involved, and they had the funding, and it's been used very, very importantly.
Yes.
Well, very good. Well, I hope that next year, when we sit down to talk about MDS, there's going to be some real breakthroughs with the array drug and rigosertib and some of the others that are coming down the pipeline, and even more genomic evidence of specific abnormalities related to the various subtypes of MDS.
I feel like a Chicago Cubs baseball fan in MDS.
Yeah.
Wait till next year.
We're going to be there. That's right. All right, David. Well, thank you so much. We'll take a break, and we'll come back and talk about myeloproliferative neoplasms.
Okay. Thank you, Jim.
So stick with us. We'll be right back.